So hi students, welcome back to pathology. Today in this session we'll be solving three high important yielding topics in kidney, that is your glomerular disease. Okay, so we'll just be doing few MCQs and gathering a lot of points in the next 10 to 15 minutes. Okay, we're keeping the session short. Now let's look at the question. When you're solving clinical questions, please bear this in mind. Each and every line is important. Pay attention to what is the age, what is the sex, what is the symptoms, and what is the duration. Okay, all this is very important. Now, let's see the question here. So the question is, this is a 8-year-old girl. Okay, it's a child. She's present with complaints of generalized swelling. So she has generalized edema, first thing. Then there is frothy urine. Okay, so she is producing urine. Okay, and it is frothy, which means it has it has other components or other something is increased in urine to give it a frothy appearance. Okay, which means there is some amount of proteins in it. Now, and also cholesterol and also lipid. Okay, now examination reveals grade 3 proteinuria. So they're already telling that there is massive proteinuria here, and there is presence of high lean and fatty casts supporting that there is lipid. Now, putting all these things, you know that, and next line very important, there is no RBCs. Okay, so the urine is free from RBCs. What does it mean? It means that there is no hematuria. Now, when there is no hematuria, what are you ruling out? What syndrome are they talking about? Here they are talking about nephrotic syndrome. Okay, so they are talking about nephrotic syndrome, and what have they ruled out? They have ruled out nephritis. Why? Nephritis syndrome में सबसे common symptom होता है hematuria. Here there is no hematuria. Now let us rule out the options. IgA4 nephropathy is the most likely diagnosis. Remember students, IgA nephropathy is nephritic syndrome, not nephrotic syndrome. So this automatically becomes, this is not your answer. It is associated with low C3 levels. Now which kind of glomerular disease is associated with low C3 level? Your C3 glomerular nephritis. Okay, but the C3 glomerular nephritis is again nephritic syndrome. So you can rule this out as well. No IgG or C3 deposition is seen on renal biopsy. Yes, this is the correct answer, because the disease we are talking about is minimal change disease over here, which in minimal change disease you see nephrotic syndrome. We will discuss this. Okay, I'll tell you why, but I'm just telling you how to rule out the options. Now what is the next option? Alport syndrome is the most likely diagnosis. Now again, Alport syndrome is a glomerulonephritis with nephritis syndrome. Okay, so you will find hematuria. And Alport syndrome, all of you know, if you have done your genetics MCQs, it is a X-linked disorder where you have mutations in the collagen type 4, which is affecting your kidneys, which is affecting your eyes, which is affecting your cochlea, and it's a inherited glomerulonephritis. When we do this glomerulonephritis in detail, I will do step by step. So abhi we will focus on the MCQs. So I told you this is also not the answer. The right answer over here is you do not see any deposition on renal biopsy. Now, so I told you, so what were we talking about? We were talking about minimal change disease here, and in minimal change disease, remember that there is on light microscopy and on your immunofluorescence, you do not see any changes. That is why the word minimal change. What is the only change you see, and where? In electron microscopy. And what is that change you see? You see diffuse podocyte effacement, diffuse effacement of podocytes. Okay, students, whenever we talk about glomerulonephritis, the examiner will always ask you or give you pictures of light microscopy, immunofluorescence, electron microscopy. When we do this, each glomerulonephritis, each subtypes, we will also make a table, and we will tell what is seen in light microscopy, what is EM changes, and what is IF changes. Okay, so for now we were discussing this MCQ was a nephrotic syndrome, or nephrotic syndrome सिर्फ two conditions में होता है. One is minimal change disease, and the other major thing is membranous glomerulonephropathy. Of course, you have FSGS also, you have amyloidosis. I'll just tell you. Okay, so you understood, right? Ruling out the options. Now let's see the difference of nephritis and nephrotic syndrome. Nephritis and nephrotic syndromes are syndromes. They are not glomerulonephritis. Okay. For example, your minimal change disease is a type of glomerulonephritis, but nephrotic syndrome होता है उसमें. Okay. Nephrotic syndrome is a syndrome. It's a number of symptoms which form a syndrome. Okay. So what happens? What is happening in this nephritic syndrome? In nephritic syndrome, the glomerulus, kidney is made up of glomerulus, glomerular tuft and capillaries, right? So there is injury to this which results in passage of RBCs. So that is why your hematuria and plasma proteins. But there is mild proteinuria, not massive proteinuria, okay? And there is inflammatory cells as well. But what is happening in the nephrotic syndrome? The filtration barrier goes away. So once the barrier goes, all your plasma proteins gets filtered, okay? So once the barrier goes, so it's at the barrier level, but here it is the injury which is occurring, okay? Now, what is the principal site of injury? We already know. Here it is the filtration barrier, which is your visceral epithelial cells or your foot-like process, which is also called as podocyte, okay? Now, another important thing is this is your triad or this is your syndrome. Okay, nephritic syndrome, you mainly have hematuria, you have various degree of proteinuria and renal dysfunction. While as remember, here you have proteinuria, massive proteinuria, 3.5 gram in 24 hours. Lipiduria, hypertension, microscopic hematuria can sometimes occur. Microscopic hematuria means patient aake nahi bolta that I am passing red urine. Okay, on microscope sometimes you find few RBCs. Okay. Now, what is the associations? Associations APGN, MPGN. Now, MPGN is the most common cause of nephritic syndrome. I'll do all this when I do in detail. But what we were saying, minimal change disease, membranous, FSGS, diabetic nephropathy and amyloidosis. These are the causes for nephrotic syndrome. So, when you do renal, you need to know what are the conditions which causes nephritic syndrome, nephrotic syndrome. That is the main important thing, and with this you can rule out all other options. Okay. Second thing is you have to know what changes occurs in each nephritis, in light microscopy, in electron microscopy and in your immunofluorescence. Okay, that's it. So, these are the main things in your glomerular diseases. Let's move on to, okay, before going, I just want to quickly draw something for you. This is your glomerulus and you have your efferent arteriole and your tuft of capillaries. Okay, now I am cutting it here and this is your diagram here. What are you seeing? Okay, first you see a basement membrane. Okay, this is your basement membrane, and in your basement membrane you see something called as your endothelial cells. These are your endothelial cells, and you see this is your basement membrane. Here you have these cells, right? So these are your visceral epithelial cells, also called as podocytes, and here you have mesangial cells, and this entire glomerulus, bahar se it is lined by, okay, you had visceral here and this is parietal epithelial cells. Epithelial cells, blood vessel के अंदर जो होता है वो endothelial cells है, ठीक है? यहाँ पर तुम्हारा blood flow हो रहा है, which has all the unwanted material. It has proteins, it has glucose, it has sugar, it has RBCs. And in nephritis, there is damage here. In nephrotic syndrome, the problem is in this filtration where all the protein, which is a heavy molecular weight, also goes off. This is your supporting cell or mesangial cells. Okay. With this, I think you must have got a clarity as to where. So when you have deposits, it can be endothelial or subendothelial. It can be basement membrane deposits. It can be subepithelial deposits. It can sometimes be mesangial deposits. Understood? Now, will be dealt in detail in the class. This is for you to just solve the MCQ. Now, let's see this question. This is a electron microscopic image, and this is electron. Whenever it's black and white, it is an EM image. And let me show that this is your, okay, so here, this is your basement membrane. This is your epithelium. Okay, this is subepithelium area, and this is your endothelium. Now, it is showing deposits. Where are the deposits? Deposit यहाँ पे है. These are the deposits. Okay. So I told you this is the epithelium. So these deposits are subepithelium deposits. Okay, subepithelium deposits are seen where? Only in two conditions. One is in your post-streptococcal glomerulonephritis. The other condition is your membranous nephropathy. Only two condition. So automatically look, PSGN nahi hai and membranous is there. So the answer becomes membranous nephropathy. If it was minimal change disease, we already discussed last class, you would have seen effacement of podocytes, right? Okay, it's not this. Now, let's move on to membranous. Membranous glomerulopathy is antigen antibody complexes are being formed and they get deposited. Now, these things, so this is the same thing, same diagram which I drew for you. Okay, so this yellow thing is your endothelial cell, your glomerular basement membrane, and this green thing is your visceral podocytes, okay, visceral epithelial cells. So where are this antigen antibody going and getting deposited? It's getting deposited below the epithelium. So they are subepithelial deposits, okay, subepithelial deposits. See the same thing they've marked over here, subepithelial deposits. Okay, so the answer is clear, subepithelial deposits seen only in two conditions, and here the answer was membranous glomerulopathy, nephropathy. Okay, now there is diffuse thickening of the glomerular wall and subepithelial deposits. Again, deposits kaha pe? Subepithelial, I told you, two conditions. Intramembranous is MPGN type 2 or your dense deposit. Where do you see tram track appearance? Where do you see humps? All these, everything, every word is important. Okay? Subendothelial deposits in MPGN type 1 and lupus. Mesangial deposits in IgA, HSP, RPGN, glomerular lupus nephritis class 1 and class 2, and resolving PSGN. Now PSGN is subepithelial, don't confuse yourself with this, but if they are asking a resolving disease and they have shown something, they can also occur in mesangial. Okay, remember the basics first and then this point. Now why have we written these things separately? Now in these three, MCD or minimal change disease, FSGS and Alport mein, there is no deposits. Okay, so there are no deposits whatsoever. Clear? Now let's quickly move to the next question. Now this is a 7-year-old child, again a child, young child. He has developed fever, abruptly has developed fever, oliguria. Okay, oliguria is, again I told you, is a manifestation of nephritic syndrome. Periorbital edema, there is no generalized edema, there is only periorbital edema. Then there is cola colored urine, smoky cola colored urine, which means it is black, okay, brownish black, which means it is a hematuria here. Okay, and when is he developing all these things? 2 weeks after recovery from sore throat. So the catch is here. Okay, so beta hemolytic streptococci, and all of you know this is what they are talking about, PSGN, post streptococcal glomerulonephritis, common in children. They have a preceding history of fever. Okay, and periorbital edema is classical. Now we know that proteinuria occurs here, but not to a greater extent, right? Now, so let's try. So this children, this is a light microscopy image. So whenever they do renal biopsy, they send us the biopsy, and we see changes here. And you know why is this a lot pink? Because they do pass stain. On light microscopy also they do many stains. When we do special stains, when we do MCQs, I'll explain each one of them. This is a periodic shifts stain. It is called as pass stain. It highlights the basement membrane and sometimes the deposits. So here you can see some deposits in the subepithelium. Okay, they are all your pink deposits here. Normally it's not seen like this, and this is PSGN. Okay, now so which of the following is false? Now in children with PSGN, they rapidly progress to form a rapidly progressive form with oliguria develops in 50% of children. Is that true? Do they deteriorate and progress rapidly? Now this particular thing is false. Okay, it is a form of proliferative glomerulonephritis. Yes. Okay, granular IgG and C3 deposits are seen on IF. This is also true. You have granular immunofluorescence. Okay, granular diffuse immunoglobulin deposition. Okay, there is injury and there is deposition due to cross reaction of the antigens. Now, dome-shaped subepithelial humps are seen on electron microscopy. I already told you subepithelial humps on electron microscopy, two conditions, membranous nephropathy and you have PSGN, and this was PSGN. Okay, so all these are correct statements. So this was a case of PSGN. Okay, something you need to remember, last NEET you had a twisted question where they had told that creatinine suddenly fell from 2 to 4, suddenly increased from 2 to 4, which means he rapidly progressed. So that time it is a rapidly progressive. Rapidly progression develops in PSGN but only in 50% of children. Otherwise, majority of the children, they eventually recover and gain their function, renal function. Okay. Now, on histopathology, what do you see? You see hypercellular glomeruli. Why do the glomeruli appear filled up? Because there are these subepithelial deposits. So, they appear hypercellular when you see. Put it on the slide. Now, rapidly progression with oliguria is seen in 1% of the patients. Then there is hematuria. Already know cola colored urine, that is the catchword, hematuria with cola colored urine, and a preceding sore throat or a preceding infection, very important. Then there is hypertension, mild to moderate proteinuria. If you're in second year, you need to mug these things up. If you are in your internship, I'm sure you all would have seen these patients, PSGN patients in the lab. I mean, in the pediatric wards, and just observe that time. You would have seen hematuria. The PG would have told you to constantly monitor BP. Okay, you keep giving urine for testing, and they have periorbital edema, which keeps resolving as the day progresses. On microscopy, what do you find? A light microscopy, hypercellular glomeruli. Glomeruli don't increase in size, but what happens? Glomerulus does not increase in size, but they appear hypercellular as if something is filled inside. Okay. Then there is subepithelial humps. Why is there subepithelial humps? Because just below the visceral epithelium, you have these antigen-antibody reaction and deposition. So that is your subepithelial humps. What is getting deposited? Your immunoglobulins and C3, and this can be beautifully appreciated on immunofluorescence as diffuse granular deposits. Okay, here there is subepithelial humps. That's it for the day. Okay, we did 3 quick MCQs on glomerular disease. To revise, very important, you need to know nephritic syndrome में क्या होता है, nephrotic में क्या होता है. Hematuria is not seen in nephrotic syndrome. Okay, in nephrotic syndrome you see massive proteinuria, you see fatty casts, you see generalized edema. So all these are hallmarks of nephrotic. Nephrotic may you have minimal change disease, membranous, FSGS, diabetic, and you have amyloidosis. These are the 5 conditions which cause nephrotic. Remember, only these 5 cause nephrotic. जो भी पूरा बाकी बच्चा है, they cause nephritic syndrome. So everything else you can rule out easily. And minimal change disease is one disease where you don't see anything on light microscopy, no changes on electron microscopy, but on your electron microscopy you see effacement of the podocytes. Okay, so this is important. And then in each and every nephritis, as we go, we have to learn what is the LM changes, what is the EM changes, and what is the IF changes, what special stains are used. Okay, and PSGN, again a very important topic. PSGN will always resolve, but in less than 1 or 2% of cases it rapidly progresses. That time there is present RPGN development. Okay, right. So I hope all of you are clear. Thank you. Have a good day.